Hey, good afternoon. Thank you for joining us and finding this room actually all the way down out here. My name is David Amar. I work at Memorial Sloan Kettering. We have a great panel for you today on practice challenges in thoracic anesthesia, a little bit of everything. And I'll start off and we'll just have our speakers come up. And, for Snap Talks, we don't have much time to, like 10, 12 minutes to speak on each topic. And we'll have some time, hopefully, for some questions at the end. So this is an area that I've done some research in probably the last 3 decades, and I have nothing else to do in my life. So that's what I do. And here's a case. So just to highlight, 65-year-old, age is important, and scheduled for right thoracotomy, and develops atrial fibrillation in the holding area after placement of a thoracic epidural. You're notified about it. These are the vital signs. He's stable, rapid ventricular rate, and denies any chest pains or any other symptoms. The history is really unremarkable for just the typical hypertension, diabetes, otherwise really unremarkable. And this is really important that he had a preoperative echocardiogram, which was totally normal within a week before. So remember, age 65, normal echocardiogram. We'll come back to that. Okay, so you want to cancel the case? Well, this is what I would do if I had nothing to do in the afternoon, but I want to present some different alternatives and perhaps challenge a little bit the level of your comfort and show you some data. And, if I had asked people in the room to show of hands who would cancel the case, I would probably guess that most of you would, and maybe we can ask you at the end. So the most recent guidelines of the American Heart Association on management of acute AFib only recommend rate control and not cardioversion of more aggressive rhythm control medications. So in green is the class 1 recommendation. And again, these guidelines get updated every 5 years. Gotta tell you, haven't changed in the last 30 years with this kind of management, a little tweak here and there. Amiodarone is not first line. As you can see, it's 2B down here. And unless you have a poor ejection fraction, then for those cases, you don't want to use beta blockers or calcium channel blockers. Amiodarone would be a choice. Magnesium only if you need more help with rate control. And this year, they've added digoxin as a secondary drug. So you often hear, well, in my institution, we cardivert them, or we give them ibutylite, and we're much more aggressive. This is a multi-center study that was done by the CT Net Trials Group that randomized patients who developed acute AFib after heart surgery to rate control alone versus the more aggressive therapy and anticoagulation. And they showed that really, maybe in the initial few days, the more aggressive therapy was a little bit more effective, but at 7 days, they were the same, as well as at 30 days and at 60 days. So the conclusion was, either strategy is fine, so why would you grab the paddles and, cardiovert and be much more aggressive? And a lot of the significant antiarrhythmic drugs have side effects, like ibutylite may cause torsade de pointes if electrolytes are abnormal. So you have to watch out, but certainly a drug that could be used. So why does AFib happen in the general population? So in the center circle are the most important risk factors like aging, genetics, but age is the most important factor. Male, much greater than female, sex and ethnicity, white versus black, is definitely a greater risk. Now, the outer circle are all kinds of comorbidities that add to the risk on top of these major risk factors. So I circled here acute illness and surgery are stressors that have been identified and gotten a lot of attention in the literature in the last few years. So that's probably what's happening with our patient. He's stressed, may not look stressed, or, again, coming to the hospital and being there. I don't think it's the pain doctor that, poked him too many times, et cetera. It just happens that the catecholamines perhaps are driven, and he flips into AFib. So what do? What the AHA recommends is once you've slowed the heart rate down to below 110 is recommended, and you want to look out for any acute MI or any signs of congestive heart failure, et cetera. If you rule out these major events, and you could tell, if the patient's sitting there, he's comfortable, is not hypoxic, et cetera, they don't recommend a mega workup, okay? They don't recommend troponins, send him for a CT angio, et cetera. Just having an echocardiogram is recommended. Now, this patient just had one, and it was normal, so there's no reason to repeat it. So if you're comfortable with a heart rate less than 110 and the echo was normal, no real structural heart disease, then I would proceed with surgery. I wrote this at a review article over 20 years ago. And again, the recommendations really haven't changed much, and I recommended proceeding with surgery with those conditions. Again, all we had at the time is really the AHA guidelines, really not much in the perioperative literature to go by. So this is an old study, very interesting, that these investigators screened over 1,800 patients that came into the hospital in atrial fibrillation or the emergency room. And they teased out of 1,800, 242, had AFib within 72 hours of admission. And look at that number, 68% of patients converted back to sinus rhythm with rate control only within 24 to 48 hours, okay? So really straightforward management, 70% or so convert to sinus rhythm. More recent data from the Annals of Internal Medicine, where they compared patients after non-cardiac surgery who had postoperative or perioperative atrial fibrillation. And they also took a group of patients that had atrial fibrillation in the hospital in an acute illness setting, pneumonia, sepsis, and other. And what they found was that the natural history of that event was exactly the same. And again, 70% of patients converted to sinus rhythm within 24 to 48 hours. Very few, only like 4% required cardioversion. So cardioversion, if they're really symptomatic, severely hypotensive, about to have syncope, et cetera. And what they noted, which has been noted in the literature, and we've published on that in anesthesiology a couple of years ago, where 1 out of every 3 or 4 patients that had a perioperative AFib event will recur within the 1 year after the event, even if they converted back to sinus after surgery. So again, back to that review article, my recommendation based on guidelines then and now, first 24 hours, rate control the patients. Again, 70% will be out of the arrhythmia. If they're still in the arrhythmia within the next 24 hours, then get your cardiology. In our institution, the thoracic surgery team, fellows kind of manage the initial events, and then they get cardiology involved. And I think that's a good time to have another drug added, such as amiodarone or buleride, to try to get the patient out of atrial fibrillation so they avoid anticoagulation. Because the 48-hour mark as I'll show you, is a risk factor for stroke risk. So how do you determine what the stroke risk? Most people use the CHA2DS2 criteria. On the left is the condition, if patients have it, and it gives you a point score. Then you add it up. On the right, as the score increases, so does your annual risk of atrial fibrillation. Now, important to realize this risk score was obtained from general medical patients, not surgical. So it's from the general medical literature, but we still use it because it was done in many, many hundreds of thousands of patients and validated. So again, if this is an annual stroke risk in the general population, doesn't mean that your post-surgical patient will be at that risk. And again, anticoagulation can cause severe bleeding in our surgical patients. So you have to weigh the risk between the cardiologists and surgeons. As I like to say, cardiologists want to anticoagulate everyone, and the surgeons want to anticoagulate no one. Okay. I participated in this AATS task force of the thoracic surgeons back about 10 years, or more than 10 years ago. And a lot of cardiologists on the panel, and they broke it down to less than 48 hours. You have to look at the CHA2DS2 score. If it's like 1 to 2, you have to consider, start to think about anticoagulation, but again, weigh the bleeding risk. Again, post-op AFib, let's say, occurs 1 to 2 days after surgery. They may start to be less at risk for bleeding. Once they're over 48 hours with the arrhythmia, then you have to, their anticoagulation is indicated. Again, if the bleeding risk allows. And so if there's no mechanical heart valves, then you can use the NOACs or DOACs, whatever you want to call them, warfarin, otherwise in mechanical heart valve patients, and also concerns with dialysis, et cetera. Question, how long do you keep the patients anticoagulated? That's another story. Some cardiologists will do it for 1 to 3 months for sure. Even if they convert back to sinus, then they monitor them, and I'll show you that in a little bit. Another topic that has taken interest is the incidence of stroke within the first 1 to 3 years after the operation, even if the patient has gone back to sinus rhythm. This data was from a large federal database, but as you could see, the hazard ratio increased over the 3 years if you had a perioperative AFib event. This large random observational study of 2 large institutions' data showed that perioperative AFib occurs in 1.8% of patients. The stroke risk is greater at 1 year. And if the stroke was attributed to postoperative atrial fibrillation, if the patients did not get anticoagulation on discharge, they're at a high risk for stroke. So if they meet criteria, it's a good thing to do. So again, back to our patients. So have I convinced anyone to proceed with the case here today? Maybe, okay. So I would, if I rate control the patient, I would do the case because I know that the patient eventually will be in sinus rhythm, or it could still be in AFib, and then it won't make any difference in management if I had a patient come to the operating room in AFib, right? We get those patients all the time. You're not going to do anything different. You stop their anticoagulation, and then you can resume it after surgery. So just one more study that was done in outpatients coming for endoscopy procedures. Gastroenterologists get very annoyed that, the patient comes in for a minor procedure, rapid AFib. Of course, the anesthesiologist doesn't want to do the case. So they were trying to kind of meet in the middle. You got a group of anesthesiologists, cardiologists. They worked out an algorithm and protocol, and one of the factors in the protocol was, does the anesthesiologist feel comfortable? Once the rate is controlled, does he or she feel comfortable continuing with the case? And they didn't force anyone to continue, but they gave you that option. And what they found was that this decreased costs and sending patients to the emergency department. So, this is another one of those guidelines that came out a couple of years ago from the AHA, ACC. And again, the acute management, of course, on the medical floor, you got to rule out PE and thyrotoxicosis and sepsis, et cetera, and what are the precipitating events and correct them, an electrolyte imbalance. But, in a surgical patient where you have all that data, it's different. But again, once you controlled the acute event, the cardiology community recommends care transition. Make sure they have a follow-up with an internist and cardiologist so that they can be properly managed. And, wearable technology is very common now. Also, what's coming up in the cardiology literature is how long to anticoagulate patients. Again, that's all being debated, and how much wearable technology affects cardiologists' management of these patients. So with that, I'll stop, and this is my email. You can all send me any questions, and I'm going to now introduce our next speaker, and it'll be Dr. Emily Teeter, who's a professor of anesthesiology at University of North Carolina, Chapel Hill. Let's see, here we go. Your slides here. Perfect. Thank you.
Great. Thank you, Dr. Amar. I have no disclosures. And our topic is pitfalls in the management of the complicated esophagectomy patient. And you could argue that this topic is slightly redundant because esophagectomies, at their core, are complicated procedures. To give you an idea or put a number on it, in the literature, the complication rate after esophagectomy is cited as high as 60%. And of the patients who have a complication, about half of them have multiple complications. So let's be specific about the types of complications. One of the most important things that I want you to remember is that pulmonary complications are of the highest order after esophagectomy. And this is also something that we can argue is under our control. We'll talk more about that. Anastomotic leaks are very common after esophagectomy. Atrial dysrhythmias, very timely topic. And in the long term, unfortunately, these patients often don't return to their functional baseline, and they may come back to the operating room for other procedures. So we're going to break this down into patient factors, procedural factors, anesthetic factors, and then I'm going to give you two pitfalls at the end, one intraoperative and one postoperative. And we'll talk about how to mitigate the risks. So if you think about the risk factors for esophageal cancer, which is the most common reason for esophagectomy, it makes sense that these patients have a high burden of comorbidity. Alcohol use, smoking, obesity. On top of that, the patients, almost as a rule, are undernourished or malnourished, and a lower BMI is associated with a higher rate of complication after esophagectomy. The standard of care is for patients to receive neoadjuvant therapy before surgery, and this is associated with a decrease in their functional baseline. From a procedural standpoint, there are multiple different approaches to esophagectomy. We'll look at these, and they've been evolving over time. So these are the three classic approaches to esophagectomy. On the left, we have our transhiatal approach, which you'll notice has no thoracic incision, but is only feasible for distal lesions in the distal third of the esophagus, whereas the Ivor-Lewis and the McEwen necessitate one lung ventilation and have a thoracic incision. Over time, we've seen a rise in minimally invasive esophagectomy, and there are advantages here. These are associated with less blood loss, lower morbidity, and a shorter length of stay in the hospital for patients. But as we know too well, they also have a large learning curve. The literature would tell us about 35 to 45 cases is typical for surgeons to start experiencing the decrease in blood loss and morbidity. In addition, from an anesthetic standpoint, these cases can be challenging. We have reduced exposure to the patient's head and to our lines. And then there's the issue of CO2 insufflation, which we'll talk more about. The anesthetic factors that are challenging, these patients are in the highest tier of aspiration risk. So when they come to the operating room, especially those with high-grade obstruction, achalasia, emergency cases, we have to be very cautious about airway management. As we mentioned, the majority of esophagectomies necessitate one-lung ventilation. Pain control is incredibly important. These patients have a high rate of chronic pain and opioid dependence. And then there's the issue of fluids versus vasopressors, which we'll talk about as well. But with every challenge, there's an opportunity. So let's talk about what we can do. From a patient standpoint, there are obviously oncologic implications to delaying these cases, and we often feel like we're operating on a very short timeline, so it's important that we focus in on the highest risk factors for these patients, which are things like tobacco and alcohol cessation, anemia, and nutrition. There's limited evidence for prehabilitation. This is a very small randomized controlled trial looking at patients who underwent about 35 days of prehabilitation prior to esophagectomy. And you'll see that the prehabilitation group did experience a little bit of a decrease in their functional status. However, they started at a higher baseline. The ERAS guidelines for esophagectomy were released in 2019, and I've put a QR code there with a link to those. And this is a meta-analysis of some data related to ERAS. And I just want to point out that the majority of these studies were released prior to the ERAS guidelines, yet they still demonstrated a pretty significant decrease in length of stay after esophagectomy when we utilized the ERAS guidelines. Likewise, the pulmonary complications that we talked about are also decreased when we use ERAS tenets. We can't directly influence the procedure that's being performed, but by being aware of what's happening in the surgical field and being able to anticipate complications, we can mitigate the risks of our patients. So for these cases, it's important that you have adequate intravenous access, blood availability. For the minimally invasive esophagectomies, you want to make sure that your lines and your tube are readily accessible to you. If you are starting to implement a minimally invasive program, you want to make sure that you have rehearsed an undock plan, an emergency undock plan, which can be really important. And then for the minimally invasive, there's also the issue of insufflation pressure. When they instill capnothorax, we may see a decrease in our venous return and may get hypotension in the operating room. This involves really close communication with our surgical colleagues and making sure we can find an agreed upon insufflation pressure that allows us to keep the pressure, the patient's blood pressure stable. And then from an anesthetic standpoint, these are the big three. So this is where we should spend our energy. The first is lung protective ventilation. We'll talk about perfusion and hemodynamic management, and then analgesia. It's important that we keep the patients oxygenated in the operating room, probably to a lesser degree with ventilation, although that could be debated. At the same time, we want to be kind to the lung. You can imagine that the lungs of these esophagectomy patients are at risk because they have underlying lung disease. On top of that, they may have irradiation. We're having large fluid shifts, re-expansion. You can see why the risk of pulmonary complications is so high. We can almost all agree that lung protective ventilation is incredibly important, yet we cannot agree on what that means. So there's a lot of literature out about this right now. I distilled it down into 3 topics that I think are mostly agreed upon, although there is future work being performed on aspects like mechanical power and mechanical work. So stay tuned for that. And then lastly, keep in mind with an Ivor Lewis that the blood supply to the gastric conduit is your right gastroepiploic artery. And they sacrifice the left, they sacrifice the gastric arteries and the short gastrics. So the blood supply can be somewhat precarious or tenuous at times, and maybe even more so if you're doing an alternative conduit. So it's important that we're good stewards of perfusion of this conduit. Historically, there were small animal studies that told us the use of vasopressors was detrimental to the conduit and could cause anastomotic leak. However, Dr. Amar and his colleagues have showed us that this is not true, that using vasopressors is safe in these patients and will not compromise flow to the anastomoses. There's no real clear guidance on goal-directed therapy. Most of the dynamic monitors that we have are not applicable in thoracic because we are lateral. We are operating on one lung. At the same time, I think a balanced approach is what we are moving toward, using fluids but not being afraid to use vasopressors when needed. And then lastly, the analgesia, as we discussed, is very important. The gold standard here, of course, is the thoracic epidural for open thoracic procedures. But as our surgical approach has evolved, our analgesic approach needs to evolve as well. And there are a variety of chest wall blocks, myofascial plane blocks that have been described in the literature, and it's important to tailor this to the surgery that's being performed. All right, I'm going to close out with 2 pitfalls. In the intraoperative setting, there are a lot of dynamic changes that happen during esophagectomies, and it is common to experience hypotension, even severe sudden hypotension. I just want everybody to remember that there is the possibility of these patients, especially with severe lung disease, to develop a contralateral pneumothorax, and you have to be on the lookout for that. At the same time, it could be, as we talked about, capnothorax, depending on the timing of the surgery. This is why it's so important for us to pay attention to what's going on and communicate with the surgical team. Lastly, in the postoperative setting, as we mentioned, these patients may come back for other procedures. In the short term, if they develop a leak, they may come back for a stent or for a thoracotomy, and it may range anywhere from having a stable patient with a radiographic leak to a very unstable septic patient. Both in the acute and in the chronic setting, we have to remember how high risk they are for aspiration, and absolutely everything you can do to minimize that risk should be done. I know this was a whirlwind, but I'm going to stop there, and I'm happy to take any questions in the wrap-up. Are you next?
All right. Up next is actually a pleasure to introduce Nicole Ginsberg, who was one of our fellows in thoracic anesthesia at MSKCC, Memorial Sloan. She's now an assistant professor of anesthesiology at Yale and hopefully being promoted. All right. And Nicole's going to speak to us about airway emergencies and non-operating.
Hi, thank you so much, Dr. Marr, for that warm welcome, and thank you everyone for joining us here today. So I have nothing to disclose. So when we think about all these interventional things, they may be less invasive and even a more efficient way to get a diagnosis or to provide a treatment, but there's always a lot of new risks that come along with it. And some of these new risks involve bleeding. But that's what I want to talk to you about today. So first, we will do a brief overview about the types of procedures in which you might see airway bleeding. Then we'll discuss the risk factors for those patients. Next, I will talk about a case that actually happened to me and was the inspiration for this talk from the beginning. And finally, I'd like to review different ways to build a team approach to the management, especially since you are in a non-operating room environment and not close to home. Okay. So in the past, a lot of people would have to get lung tissue biopsy either in the chest or in a mediastinoscopy. So now there's these increasing popularity of these procedures, like I said, and they can happen anywhere and with or without anesthesiology. So a lot of times these could be happening with a conscious sedation nurse. We don't even know it's going on, and they can end up having a number of problems. Here's some examples of the minimally invasive procedures that can cause massive hemorrhage. And does this mouse? There we go. So here's like the typical endobronchial ultrasound transbronchial needle biopsy, or EBUS. Up at the top, you can see it's a percutaneous CT-guided biopsy. This is more of an example of a therapeutic intervention for ablation or removal of tumor. And finally, I don't know if this is familiar at your institution, but increasing in popularity is the famous robotic bronchoscopy, where they actually, as you can see, there is a robot driving the bronchoscopy through the endotracheal tube, and they have fluoro and CT capabilities to reach more peripheral lesions. So the major serious risk of these procedures and what I want to talk to you about today is airway bleeding and how to manage it. I think there's a range of bleeding, and what I'd like to really drive home for you to understand is that it's not so much the quantity as much as the effect on the clinical picture, because even small amounts of bleeding can cause major airway obstruction, asphyxiation, and ultimately death. You see a lot of high rates of complications in CT-guided transthoracic biopsies specifically as well. Some of the risk factors I found when I was reviewing the literature for these topics happened to do with things like anatomy of the vasculature and the pulmonary artery size, whether patients had pulmonary comorbidities, emphysema, if the lesion was deeper or harder to get to, other comorbidities, either metastatic disease or certain infections. Knowing these risk factors is important because it helps you to develop a good and adequate preoperative planning. So patients like this who you have high concern for bleeding, these should take place in the main hospital with anesthesiology involved from the get-go. There should be notices ahead of time, not just to anesthesiology, but the nursing team, to make sure the nursing team is a team that's aware of how to manage these complications. An emergency cart, which we'll talk about later, the things you should have available. And then also know how to reach out to either interventional radiology or interventional pulmonology or even CT surgery if you have that at your hospital. And of course, I know this isn't as easily available to everybody, but know how to activate an ECMO protocol. It's just much easier to have a plan in place, even with the emergency happening, so that you know how to activate in a quick time. So this is the case that inspired this talk. It's a 66-year-old female. She had a history of lung cancer with a couple of previous pulmonary resections in the past, recurrence of disease, and she presented for robotic bronchoscopy. The robotic bronchoscopy went without problem, and then during the EBUS, the resident texts me, "Hey, we're having some bleeding." I happened to be going onto VV ECMO in my other room, so I was like, "Oh, okay, can you please call Dr. Schwartz? He'll come help you," because I didn't think it was a big deal. And Dr. Schwartz, one of my colleagues, is excellent. And then Dr. Schwartz calls me probably 5 to 10 minutes later, "You really need to come in here." I'm like, "Okay." So here I come. So they basically started having bleeding in the endotracheal tube, with decreased ability to ventilate and complete loss of end-tidal CO2 and complete loss of ventilation. And this actually happened for a full 15 minutes. So what do you do in these situations besides freak out? You don't freak out. You have a plan in place. You call for help from your colleagues, from the backup team, suction. So in a lot of these cases, like at MSK when I was a fellow, I felt like there were a lot of these cases happening in natural airway conscious sedation cases, and then anesthesia had to go, and all of a sudden, you're like, what's going on? Suction, 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 whether the bronchoscopist is suctioning or you're suctioning. And then, of course, with every emergency as anesthesiologists, we start with our favorite A, airway management, which I'll talk about in the next step. But start preparing emergency equipment, assign roles to the people in the room to get those things for you. And then you need to discuss, with the proceduralist what they need from you. And what do I mean by that? So here's where you really start to see two competing priorities. Us as an anesthesiologist, you want to protect the non-bleeding lung, you want to ventilate the patient, you want to oxygenate them, but the proceduralist is going to want to intervene, stop the bleeding, and sometimes our management can actually get in the way of that, which we'll discuss a little bit. Positioning too. Make sure you put your non-bleeding lung down if possible. And of course, if you're in the middle of a basement somewhere, not at the main hospital, consider going to the main hospital. So as far as airway management, I recommend large size endotracheal tubes, anywhere between 8.5 to 9. Intubate however you see fit with whatever tools you have availability to. You may need to isolate the lung for protection from blood spillage. Now here's this problem with protecting the lung. You can do it with a bronchial blocker through your large bore single lumen tube, but then all of a sudden you're blocking the proceduralist's ability to get to the bleeding and intervene. It sits very uncomfortably to not be able to fix a problem when you feel like you could, but sometimes you have to have that conversation with your proceduralist and live in a little bit of fear. The other option for one lung ventilation is you can place a double lumen tube. I don't recommend that because the really good bronchs are very big and they can't get through the lumens of the double lumen tube. Plus, it just issues with staying intubated after. I personally would put in a blocker if possible. And plus the blockers could tampen out a bleed, and it can stay in after for, I think, up to about a day, if you need that. But if your interventional pulmonology friend can't stop the bleeding, then you need to make sure that you consider getting someone else in to help you and also to put up that bronchial blocker. Oh, and also my plug, like Dr. Teeter, is if you are on one lung ventilation, to always do protective lung ventilation. Here's just a summary of airway devices that I, typically talk about and use. Like the endotracheal tubes. I show a bronchial blocker here. It doesn't have to be that one. It can be any one that you have at your institution or that you feel comfortable using. And because working with interventional pulmonologists can be a true pleasure because they're very handy with like Fogarty catheters, which they sometimes use as bronchial blockers, and other drainage sets and biopsy forceps to go in and pull out clots. So just a quick summary of the steps after you call for help and you get all your equipment and you're ensuring that you're hopefully ventilating the patient. Not that I did during this time, but we did support hemodynamics and obtain further access, large bore IVs, arterial line to send labs, and then calling for your other specialists as well as maybe early ECMO consideration, since it is a lot of work to mobilize an ECMO team. And while this is kind of outside the, my talk here, I do want to make a plug that when you are resuscitating, you really should focus on the correction of coagulopathies and not just and target on your resuscitation to avoid further coagulopathies because of dilution or not giving the right balance of blood products. And sometimes that means sending a TEG. And all of these actually can be problems in the non-OR areas because it's really hard, at least in our hospital, there's always a confusion about who brings blood downstairs, who gets the blood, and the idea of where does the TEG go. There's a lot of conversation and you're in the middle of emergency. The last thing you want to do is have those conversations. So what can your proceduralist do to help you while you're, figuring it all out? So there's some things that they can do, and the nursing team in those rooms should be familiar with that equipment so that they can get it for them. So they can either put cold saline, topical epi as a vasoconstrictor, tamponade with the bronchial blocker, or do other ablative therapies. If that doesn't work, you can also call interventional radiology for embolization. And that's assuming maybe all these things are close together or maybe not. We're lucky that our ion bronchs take place in the main operating room next to cardiac and thoracic surgeons. You'd have to go downstairs to go to IR. So just my quick plug, at my institution, I'm considered the princess of ECMO, the queen of ECMO sitting in the audience, but early consideration. And like I said, it requires a lot of people, from a CT surgeon, the perfusion team, having the availability of an ECMO circuit, and discussing where those cannulation sites are gonna go. So at least have that early conversation, even if you don't end up needing it. And just quickly, VV ECMO is what I would consider here because that's aimed for respiratory support in which there is preserved cardiovascular function, whereas your VA ECMO would be a combined cardiopulmonary failure. The nice thing about this is that you have, now we have unlimited time for this intervention because you're on ECMO. So you're oxygenating, your lungs don't need to be moving necessarily and getting in the way of the interventionalist. And as I discuss also here, there's no competing interest. You can go post-op on ECMO to the ICU. The patient can be just still. So you're just one person in a basement far, far away from home. How do you do it all? Because it's a lot to do. So managing a team. So I really believe in a team approach, and I think most of us as anesthesiologists who supervise, or even if you don't, do, because you rely on your nurses and your techs to help you so much. So as anesthesiologists are securing the airway or getting access and resuscitating, rely on your surgical colleagues or even your interventional pulm colleagues who are critically care trained if they need to help with access while others are temporizing the bleeds. The nurses, as I said, need to have familiarity to obtain those medications. And don't forget to appreciate your anesthesia techs who can run labs, surgical techs, and the perfusionists who keep that ECMO going. Everybody has a job. And the other thing I would recommend is simulation and training, because when people practice, they're more confident and they're more familiar with each other. I think creating a reference guide or a checklist can help take the guesswork out of it. And I borrowed this as an example from my colleagues at Memorial Sloan Kettering, because I think it was a very comprehensive and clear kind of what they say when you have an emergency, how to activate that emergency, then what equipment to get. And off on the side here, you can see what equipment they have in their emergency cart, what drugs they have, how to call for help, and then other considerations. You can customize this to your institution, make it applicable so that you have that too. So in the case of my patient from a few years ago, we did get access. We discussed the placement of a bronchial blocker, and the pulmonologist said he would like to be able to intervene with the bleed. So again, demonstrating that dichotomy between the proceduralist needing to fix a problem and our desire to ventilate and oxygenate a patient and protect the non-bleeding lung. Ultimately, they did achieve hemostasis. And we were able to ventilate the patient. We improved the SAT to 100%. We actually extubated her, sent her to PACU, and kept her for a long observation. But she was very cranky and wanted to go home because her friend could only pick her up for a certain amount of time. So she had no apparent sequela from that event. So when I think about this case in summary, just don't forget that even a little bit amount of bleeding can cause devastating outcomes. Develop protocols, develop checklists. I know sometimes, at least in my hospital, we're doing this all the time. There's a checklist, a pathway for everything, and you feel like there's no room for human interpretation, but it can be helpful in an emergency. It's much harder to think clearly. Make sure you engage with the other multidisciplinary teams in your hospital. They're great resources. And just don't forget that sometimes you do have to do uncomfortable things like not ventilate or not place a blocker in order to move forward with the ultimate treatment of bleeding. And a great quote, if you fail to plan, you're planning to fail. So preoperative planning is really important, and especially mobilizing the resources and making sure your procedure is happening in the right place. And that's Yale School of Medicine. If you have any questions, you can email me. I have there. So thank you for your time.
Hey, thank you, Nicole. That was a great lead into our final speaker, Dr. Andrea Miltiades from Columbia Presbyterian, where she heads the ECMO unit as part of the cardiothoracic team there. So, pleasure. Thank you, Andrea.
Hi, thank you so much, and thanks for everybody for staying late on a Sunday. I don't have any financial disclosures, but I am open if anybody has suggestions. So today what I hope we'll talk about is ECMO 101, some thoracic surgery indications for ECMO, the logistics of awake versus asleep ECMO cannulation, and if we can get to it, some lung transplant indications for ECMO. So I hope after this talk, you'll be able to recite the recipe for success for ECMO to replace the lungs completely, to list some surgical indications for which VV or VA ECMO might be useful, to name 2 patient-specific indications for which VV or VA ECMO might be useful in routine thoracic surgery, and to explain why some centers are using ECMO for all lung transplant recipients. So ECMO is very useful in thoracic surgery, where our usual tools to aid in gas exchange and or support the patient's circulation are inadequate, like this huge mediastinal mass that compresses the airway and invades the great vessels. And this is a picture of the patient breathing spontaneously. Or as Nicole just spoke about, you can be the best anesthesiologist in the world, but experience and skill cannot overcome this level of pulmonary hemorrhage. But ECMO can help get the patient safely through. Last year when I gave this talk, there was a different audience. So can I just pull how many of you use ECMO at your institution? Okay, most of you, great. So we can move on to the lung transplant stuff at the end, I hope. VV ECMO, as Nicole explained, takes blood out of the body through a vein and returns it back through a vein and only provides lung support, whereas VA ECMO supplies both gas exchange and circulatory support. Major differences I'd briefly highlight here are that for VV ECMO, you need normal or a hyperdynamic heart, and that the VA ECMO offloads and bypasses the LV partially, but it does increase the afterload. And then I'd like to highlight the risks. So the biggest risk of VV ECMO is that you have inadequate oxygenation due to recirculation or inadequate support if the patient suddenly needs cardiac support. For VA ECMO, you can have north-south syndrome or differential upper body hypoxemia, limb ischemia to the site where the artery is cannulated, or LV distension. So what do you need to make VV ECMO successful to replace the lungs? You need an adequate vessel size to be cannulated, and that's both the femoral vein for the inflow and the IJ to be cannulated for the reinfusion. You need a native adequate cardiac output that's efficient, and you need adequate drainage as well as flow, and then limited recirculation. And to decarboxylate the patient, you only need a low flow, maybe 20 to 30% of the cardiac output, but for oxygenation, you need more flow, up to about 60 or 80% of the cardiac output. And then when I talk about recirculation, what I mean is that if you're reinfusing here through the SVC-RA junction, that the blood would, instead of going through the patient's heart and to the body, go right back into the ECMO circuit, and that's called recirculation in VV ECMO, and that's something you want to avoid. For VA ECMO to be successful, again, you need the adequate vessel size for drainage, and the drainage is usually what limits the flow in VA ECMO. And then you need a good enough sized artery for the return. The goal is about a 19 French. You want your delivery of oxygen to be threefold of that of the consumption, corresponding to a mixed venous of about 66. And you can get up to full flow if you have enough drainage on the ECMO. And you also want to monitor and avoid the risks that I talked about. And this is an important thing that we'll probably need to decide for the surgeons, is if we're going to do ECMO-assisted thoracic surgery, can we wait until the patient is under anesthesia to institute the ECMO, or do we have to do what they call, quote-unquote, awake ECMO cannulation? And this is really a multidisciplinary approach and discussion that you're going to have. And it's really up to you as the anesthesiologist. So the first thing you're going to need to decide is, can you intubate and ventilate based on however their airway is? And then if you can't, the next thing you need to decide is, does the patient need circulatory support? So in any of these cases where you can't intubate or ventilate the patient safely, you're going to need to do an awake approach, either VA ECMO if the patient needs circulatory support, or VV ECMO if they only need lung support. And if everything seems to be stable, that you can intubate and ventilate them, that their hemodynamics seem okay, you're only really going to need to give them lung support for part of the operation, you can do a post-anesthesia induction of VV ECMO. So how is this actually used in real life? So the top 5 published uses for ECMO-assisted thoracic surgery are those for what we call open airway surgery or complex tracheobronchial resections, those in which patients have a limited lung function or a single lung, and then big masses that involve the aorta or left atrium. And there's also one very large case series where they used ECMO for lung volume reduction surgery. So let's talk about the most common major thoracic surgery indication. This would be for a complex tracheobronchial resection and reconstruction, or what we would call an open airway surgery. And a major use of this is when the tumor is invading one of the major airways and you need to completely transect the airway. So in these cases, ECMO is able to replace jet ventilation or something terrible called cross-field ventilation, where you intubate the distal airway, and even allow for a minimally invasive approach. This is complete apnea and a robotic approach to resecting this type of airway tumor that's invading the whole airway. And also, as Nicole was saying, it can be used post-operatively to aid in anastomotic healing without the added pressure of the endotracheal tube. ECMO can also be used for more routine thoracic procedures like cancer resection in patients who maybe only have one lung, and they wouldn't tolerate lung isolation, not to mention whether or not your surgeon is going to tolerate a selective lobar blockade. ECMO can also be very useful for procedures in patients who have hypercapnic respiratory failure, who want to undergo lung volume reduction surgery, which could greatly improve their quality of life. These patients would otherwise not be candidates for this procedure. And with a low level of ECMO support, you can get these patients safely through the procedure, as well as give them lung rest for about 3 days post-operatively and get them great outcomes. So how are we actually going to do this? So let's say we think the patient's safe to undergo anesthesia and they only need ECMO for lung support for part of the surgery. The patient's going to come to the operating room. You'll put the standard monitors on. I do recommend a right radial arterial line just in case anything goes south and you need to cannulate VA ECMO. You'll induce the patient and intubate them and secure the airway. And then you'll place a central line if that's planned for the procedure. I would recommend doing a left-sided central line just in case the surgeon needs to use the right side for the reinfusion cannula. And then the ECMO will be timed per the surgical team. How is this actually done? So percutaneous VV ECMO cannulation is done usually ultrasound guided. They get access, they put the wire in the vessel, they do serial dilations of it up, and then they place a large cannula over here in the femoral vein. And usually the reinfusion cannula is easily placed in the right internal jugular vein. You can confirm the tip position either with TEE or with an X-ray. And you want the drainage cannula to be at the RA-IVC junction and the reinfusion at the SVC-RA junction here, and a good enough distance in between them. And then you want to confirm adequate flow by the numbers on the circuit. And you also want to visually inspect the two cannulas, the one that's coming out of the patient, which looks darker, and the one that's going back into the patient looks more red and more oxygenated. So that's kind of a visual confirmation that you don't have too much recirculation going on. So to prove to you that this can actually work, that ECMO can provide adequate oxygenation and decarboxylation, these are two patients in which there was complete apnea, and VV ECMO was used to assist thoracic surgery. And here are their ABGs. So they did the initial part, and then they cannulated the ECMO here with apnea. In these yellow boxes, and you can see over here on this line that says the PaCO2 was 40. So they were able to maintain completely normal blood gases throughout these two major surgeries. And generally, ECMO can also be indicated for any patient undergoing thoracic surgery who either develops hypoxemic or hypercarbic respiratory failure that's not recoverable, not just the indications that I talked about earlier. So we discussed the indications for VV ECMO. We can discuss the considerations for VA ECMO, which also provides a circulatory support. And this is the case that I showed you before. This patient had a very large mediastinal tumor. Thankfully, it was posterior, but it was encompassing the aorta and compressing the airway from the posterior area. So with VA ECMO support, they were able to clamp the aorta and fully resect and replace it with a Dacron graft. And this surgery otherwise would require full cardiopulmonary bypass, which makes it much riskier for the patient. VA ECMO is also very helpful to use as a bridge. For example, if you have a young patient who's listed for a potential heart transplant, but then develops a big empyema and needs to go for a VATS to drain it, it can bridge them through that surgery just as temporary mechanical circulatory support and get them hopefully to be listed and through a life-prolonging operation. So how are you going to do this? Usually for the cases that really need help from the VA ECMO, it's usually awake. So what you would do is you would take a lot of care to not collapse this airway further by giving minimum sedation. You would place, again, a right radial arterial line, and then I would argue to still place a left internal jugular central line, just in case you need an additional venous drainage from the right side. Again, in a percutaneous fashion, usually the femoral vein and artery would be cannulated. The ECMO would be instituted and fully flowing, and then after that, you would intubate the patient, induce general anesthesia and intubate them. And then there's one thing to note is that a lot of times these patients have limited circulation through their lungs, so our inhalational agents might not get to them as well. So definitely don't forget your TIVA in this case. So in summary for these, VV ECMO is beneficial in thoracic surgery patients who either need complex resections or especially open airway surgery, or those who need routine thoracic surgery but have either a single lung or very limited lung function. VA ECMO is beneficial in thoracic surgery patients who either need complex resections requiring hemodynamic support in addition to the lung support, or those who need routine thoracic surgery but are of an unacceptable cardiac risk. I don't think I have much time to talk about the lung stuff, but I would definitely love to do that over Zoom if anybody is available. I would just talk about the intraoperative ECMO complication rate. So this is definitely not without risk. The most frequent complication is a re-exploration for bleeding or some sort of revision that these patients would need with a pretty high incidence. You could have a big incidence of thrombosis or vascular complications. You could have a very low rate of stroke, which is reassuring, or you can have a limb ischemia. So thankfully, these complications are pretty rare. And I would like to thank you all for your attention and your support, and my colleagues at Columbia and the whole perfusion team, the thoracic surgeons I work with, and our ACTA division.
Thank you, Andrea, and all the speakers. I'm going to come up and entertain some questions. Any questions from the audience? I guess we did a great job. Everything's all clear. Oh, okay.
I have a question for Dr. Tito. What's your strategy for immediate post-op care of a major esophagectomy like over to Iowa Lewis? Because at our institution, I find if we fly somebody that we think needs to go to the ICU, they stay in the ICU for 24 hours. They look great. They send them out, and then a day later, they develop their leak.
Yeah, that's an interesting question. At our institution, there's surgical oncology, and then there's thoracic surgery. Same procedure. They handle them totally differently. Surgical oncology, they go to the floor. Thoracic surgery, they go to the ICU. So our experience is a little bit heterogeneous depending on who's doing the surgery, which is really interesting. Most of the time, though, I found that they can go to step down if they're stable, if we don't have any concerns. I'm looking at Dr. Cook in the front row here, who's my colleague. Anything to add, Ariana? Yeah, but it is hard. They do come back pretty frequently.
I mean, at our institution, it's similar. They'll stay overnight in the PACU and then go to the floor. It's rare to have a patient like remain intubated or things like that. Unfortunately, they are frequent flyers to the ICU later on. But sir, you had a question?
Yes, so I had some comment about a surgeon doing invasive surgery. That broncho blocker is better than having a exposure. Have you ever had this kind of?
I think it's probably somewhat institution and surgeon dependent. Our surgeons are not huge fans of bronchial blockers for exposure, so we typically use double lumen tubes. But I'd be curious to hear what the other institutions are doing.
Well, so right-sided thoracic approach with a bronchial blocker is more challenging than if it was on the left. Okay, I mean, years ago we used to have a surgeon that used to do a left thoraco-abdominal approach, but that was like, it's not really commonly done. So we rarely will do a blocker for an esophagectomy unless there's some really challenging airway that, or they couldn't get a double lumen tube.
Yeah, to David's point, the right-sided blockers are just they're challenging to get positioned, below the carina, above the right upper lobe. And with the robotic esophagectomy, you're so limited, at least we are, to the head of the table that you really want to make sure you have a good definitive airway isolation. You don't need messing with the blocker under the drapes with the robot on top of you.
I also wanted to add one point to like Emily's presentation about the pneumothorax. I mean, besides patients that have, intrinsic lung disease, we also have some pretty aggressive surgeons that when they dissect up in the up near the hilum, they cause pneumothoraces during the procedure, and sometimes it's right side, left side, both sides. So my colleague Dr. Pedotto and I deal with that on a daily basis. So it's challenging.
Can I ask a question of Andrea? Sure. For the VA ECMO, how are you handling heparin?
So it depends if it's the cardiac team cannulating or the thoracic team cannulating. They prefer the minimum amount of heparin necessary. So for short cases, even for lung transplants for VA ECMO, we give very, very minimum heparin and don't check an ACT. I think the textbook approach is to target an ACT somewhere around 200 or so and monitor it frequently for VA ECMO.
Yes.
To get outside of the procedural suite, nebulized TXA has started taking a bigger role for management. Have you ever seen either a pulmonologist or use personally topical TXA for intraprocedural?
Not topical. I've had patients come like from the ED, like nasal bleeds and stuff, and they're either packed with, the TXA and pledgets or doing inhaled. I haven't seen them use it. They just put it in the airways, what you're saying?
Some of our interventional
Yeah.
pulmonologists instill it.
But that would be a great example of something to keep in the cart with the topical vasoconstrictors as well.
That's a good point.
Thank you.
Yeah, we do that. Anyone else? All right, well, thank you so much for your attention. We have to have a group picture, right?
Let's do the picture. Great.